Hello and good afternoon. Thanks for attending our talk, Rehabilitation, What Can We Learn from Other Disciplines? So, it's said that the crossroads of innovation are between two different disciplines, and that's where I think the role of rehabilitation, physical therapy will be with abdominal wall reconstruction or hernia repair. I actually think we have a lot to learn for our two disciplines working together. And I think the principles we're going to talk today, while they're applicable to ventral hernia repair, and that's what we're focused on, in a broader context, it's really related to many aspects of general surgery where laparotomies are being performed, or even laparoscopic surgeries, bariatric surgery, transplant surgery, surgical oncology, uro oncology, and so forth and so on. So without further ado, so the objectives today are to understand the similarities between abdominal wall reconstruction and extremity reconstruction. We want to review the concepts associated with physical therapy, and we want to learn how physical therapy is being used as an adjunct to abdominal wall reconstruction. So for me, I'm a plastic and reconstructive surgeon. As part of our training, we are trained in hand surgery, where physical therapy or occupational therapy plays a very important role. And as plastic surgeons, we also work closely with orthopedic surgeons. And a lot of the principles here are coming from orthopedic surgery and really physical therapy for orthopedic surgery. And in a way, one can think that really this is orthopedic surgery and we're really 30 years behind and just playing catch up. And that's where the innovation lies. So let's talk about this a little bit more. Let's talk first about anatomy and function. So many of the general surgeons in the audience will be very familiar with the picture on the right of the abdominal wall, the linea alba, and the different layers of the muscle and the fascia. And when you look at it in closer up, what you'll see are the oblique muscles and the transversus form a semilunar line where there's no fusion per se of the fascia, but as the fascia goes around the rectus muscle, and obviously this depends on which layer of the abdominal wall you're looking at, the cephalad, sort of the portion or the caudal portion of the abdominal wall, but they all fuse in the linea alba. And while we call this fascia, another way to think about the linea alba is the central tendon of the abdomen. And really, if you look at extremity anatomy, so take the muscles, the adductors of the hip, semitendinous gracilis sartorius, these all fuse in the pes anserinus. And if you look at the gastrocnemius and the soleus, these fuse in the Achilles tendon. So in a way, the linea alba can be thought of the pes anserinus or Achilles tendon. And those are only a couple of many examples that exist. The abdominal wall is a musculoskeletal unit with nerve innervation. So anytime you cut through or disrupt that linea alba, that tendon, it's the same thing as what an orthopedist or a plastic surgeon may have to deal with where we're dealing with tendon reconstruction. And so the same principles apply in both the surgical principles, but the rehabilitation principles, right? You would never expect to fix a person's extremity, their tendons, and not have them see a physical therapist. Yet, we all the time operate in the abdominal wall and don't have people see physical therapists. So I think it's time for a change. And I think that's the evolution of the next phase of abdominal wall repair. What are the similarities between the extremity skeletal muscle and abdominal wall skeletal muscle in terms of how we treat sort of surgeries? So both of them involve physical therapy, and that's what we're going to talk about today. You even hear about Botox, that's used for spastic extremity muscle disease, and certainly that's catching on or being investigated now for abdominal wall repair. Surgical release or lengthening of the muscle tendon unit. So for extremities, that could be Achilles tendon lengthening. Those are tenotomies, we call them. And in abdominal wall repair, that's a component separation, whether it's a TAR or an anterior release. You can splint an extremity. You cannot really splint an abdominal wall. Maybe we add some bolsters or we're adding some compression garments to make the patients feel more comfortable, but I'm not totally sure that's truly a form of splinting. We don't do tendon transfers for the abdominal wall per se, but we do them for the extremities. And application of mesh, obviously that goes on in the abdominal wall. And the orthopedic surgeons don't usually use this for tendon repair except in unusual circumstances where there's a lot of tension on soft tissue reconstruction and poor soft tissue quality. So from a physical therapist perspective, they think about patients with the World Health Organization as an international classification of functioning, disability, and health for ventral hernia. And this is a bit complicated, this slide, but this is how a physical therapist approaches the patient. So you'll see I'm collaborating with Mike Schmidt. You saw his name on the title slide, and this is sort of Mike's work, where they look at body functions and structures. We're going across the middle left here. The hernia repair, they think about trunk strength and endurance. They think about their activities, activity restrictions. They think about their participation, their quality of life, social engagement. And these things are all in their interview process taken into their treatment plan. So one of the things that will come up, and I warn people, is if we as surgeons are going to develop treatment plans but not care for the patients with the treatment plans, I'm not sure this is the best service for the patient. I really think that physical therapy rehabilitation plans, while developed for physical therapists, also need to be managed by physical therapists because, for example, of this WHO, what's called ICF classification, to tailor it for the patient and help them through their recovery. The next thing that a physical therapist will do will be some objective testing. So they do a trunk raising and a double leg lowering test. Each of those are scored 1 through 5. Cumulatively, they're scored 1 through 10, and they're for abdominal wall core strength. The upper one, you can see an A, which is the upper rectus muscles. That's more a measure of endurance. And I'm not going into the details here of the slide. We can talk about that at another time. That's the purpose of the trunk raising and sort of the technique of how they do that. And then the lower leg raising is a measurement of strength. Here you can see the hands sliding behind the back, so you want to tilt the pelvis up to get the lumbar aspect of spine onto the table. And then they do leg lifts. And again, it's a scale of 1 through 5. And the details of how this is done specifically, this is not for a surgeon necessarily to do. That takes a little bit of details for how these tests are done. But again, we're happy to share that information at the end of the talk if anybody's interested. Then what you do is you take the strength score and the ICF interpretation, right? So that's a qualitative interpretation. And you add them together. And what we're doing at Duke is doing them into classified into 3 things. 3 is easy: low, medium, and high. And effectively, if the score is less than 3, it's a low intensity rehab program. Medium score 4 to 6, it's medium intensity, and high is greater than 7 score with a high intensity program. And what that then we do is we look at the exercise in terms of frequency, time, type, and intensity. And that increases from low to high based on whether you're a low, a medium, or a high person. We effectively want to get the patient back to their preoperative functioning level. So somebody who's a high functioner really needs a little bit more of an aggressive program than somebody who's a low functioner. And really what we find is some patients don't know what to do today, and so they do nothing for 3 months, which is just the wrong thing to do. Or some people are just too active. So here gives a much more controlled sort of system. And by working with a physical therapist who's available, the patient can ask questions of the expert about what to do in their training program and how to manage the different issues that arise. And surgeons normally, we're not able to answer that question because we don't have the knowledge. Here's what we're doing. Here's an example. This is week 8, but we have a 12-week rehabilitation protocol or 4-month protocol. So we would give, for example, here, there's a walking exercise, the very second row there. There's a title row and then the second row. So this may be a low performing person with a single leg hip bridge, a modified plank, and a modified side plank. They're instructed, you can see how to do the exercise, how to hold it, how many times to repeat for how many sets. And these are instructed to do it Monday, Wednesday, Friday, and Sunday. They provide check boxes to make sure they're compliant. And then they turn the page and go to week 9 and week 10 where the exercises progress. So a sample, okay, of what this might look like. So let's say we have week 1 up top with the same 3 exercises of the transversus kind of holding pressure in the right position, a sit stand with your legs only, and just a leg raise, okay, or sort of a leg slide. And you can see that for low people, they're doing 10 repetitions for 2 sets. Medium people are 10 to 15 for 2 to 3 sets. And high are 15 to 20 for 2 to 3 sets. So again, accurate assessment preoperatively is important. And then again, what you can see below is a week 4. So now there's a progression of strength, more repetitions, same repetitions, same sets, but different exercise, a little bit more difficult. Lastly, what we see is that physical therapy can serve a very important role for pain management. We all know about the opioid crisis and the desire to get patients off opioids. So it's a structured early intervention physical therapy program that decreases pain and fear. There's a lot of fear in movement. And our physical therapists are able to apply cognitive behavioral therapy approaches. You can see some of those approaches: cognitive restructuring, graded exposure, and so forth and so on. And again, you need a trained physical therapist who can communicate with the patient, who has the time to sit down and talk about their pain issues, what they're doing that's causing pain, and how to begin to work through this. So again, really important role for physical therapists in pain management, and again, for abdominal wall reconstruction or ventral hernia repair. How do you record all this? How do you measure it? What are the outcomes? Patient-reported outcomes are here. We know that. So for physical therapists, an appropriate scale that's validated is the PROMIS 29. Here's a sample of a few questions with Likert domains. They include physical function, anxiety, depression. So we're able to measure the patient's outcomes prior to surgery, and then successively post-operatively throughout a year period to see how they're doing from their perspective. This talk would be incomplete if I didn't mention the American Hernia Society has the Abdominal Core Health Quality Collaborative, which does involve a rehabilitation program. What I will say about this is, while the exercises are there, what I caution that the program doesn't have, at least, and I may be wrong about this, and excuse me if I am, but I don't see where a physical therapist is designing the program for the patient, number one. Number two, there's no physical therapist following through, guiding the patient, and giving a surgeon the tool to give this to the patient without a way to guide them through it. We probably need a little bit more. And the third thing is, we don't know the outcomes. We don't really know which tools to use for patients and what the outcomes would be. So as a society, for the AHS, if we recommend this, we have to be careful that this is still really, truthfully, the quality of this, because we don't have the outcomes to justify the recommendations. Rather, we have tools to use, but the question is how to use them and apply them. That's what we're trying to do at Duke right now. So our future work is to continue data collection of our ventral hernia patients. We've now had about 100 patients that we've been in our system, so we're analyzing the data now. We really want to expand our program to collaborative centers. So we're talking with Dr. Hope at New Hanover. We'd welcome collaboration. Anybody else in the audience wants to work with us, please contact me. It's not just the paperwork and how you do it, but it's the know of how you communicate with the patient and get the physical therapist working with office staff to make it easy. That's what we do. And we do it so that it doesn't interfere with surgeons. We work around the surgeons to make it easier. Many of the surgeons in the audience don't believe that, and I understand why, because I'm an academic surgeon myself, but it really is true. It's the staff, support staff, APPs, who make it easier and enable us for the patient. And last thing, we're expanding the rehabilitation program to non-operative and post-operative inguinal hernia repair, right? That's the next thing. And of course, one can imagine, as we talked about earlier, the other hernia or abdominal wall surgery uses. If you are interested in this, contact Michael Schmidt. He's our physical therapist who's leading the charge. Mike is wonderful. Here's his email. You can take a photo of this or write it down. I'm Dr. Levinson. I'm Howard Levinson. Howie is what I go by, but it's howard.levinson@duke.edu. We'd be happy to hear from you, share with us our information, and work together to collaborate. So thank you very much for your time. We appreciate you joining the webinar and podcast, and hope to hear from you soon.